So the addition of rituximab to chemotherapy is really the backbone of therapy in B-cell malignancies, and we recognise, for example, in follicular lymphoma, induction chemotherapy with rituximab followed by maintenance rituximab brings forth really very impressive progression-free survival results. However, the delivery of IV rituximab is challenging. It's challenging to our day wards, it's challenging to patients because of the time it takes to deliver. So therefore you can imagine there's very clear advantages for changing to a subcutaneous formulation of rituximab. So the development of the subcutaneous formulation of rituximab, two things have happened. One of those is that there's been a 12-fold concentration in the rituximab to provide a much smaller injection volume, just a little less than 12 mils, and also it's been co-formulated with human recombinant hyaluronidase, and what that allows is reversible cleavage of the hyaluronic acid in the subcutaneous tissue and allowing larger injection volumes to be given. So subcutaneous formulation of rituximab is given just over approximately 6 minutes, and also there's been a change to a fixed dosing schedule of 1400 milligrams flat. Now that dose of 1400 milligrams was determined from the phase 1b Spark-Thera study and some extensive pharmacokinetic modelling. And what we've done is we've taken forward that flat dosing of subcutaneous rituximab to a multinational phase 3 study called the Sabrina study. And this was in patients with follicular lymphoma who had previously been untreated and had a clear indication for therapy according to conventional Guelph criteria. And they were randomized on a one-to-one basis to receive either CHOP or CVP chemotherapy for 6 to 8 cycles, and either IV rituximab given at conventional doses or subcutaneous rituximab given at a flat dose of 1400 milligrams. The chemotherapy backbone was a choice of CHOP or CVP given for 6 to 8 cycles. Those patients who were randomized to subcutaneous rituximab received their first cycle of rituximab given by the intravenous route. And that was a response to investigators' request for safety. Those patients achieving a partial response or a complete response continued to maintenance therapy according to the study arm, either subcutaneously or intravenously, for a period of 2 years, given every 2 months. And what we demonstrated, first of all, was in terms of pharmacokinetics of the 410 patient population in the study. We demonstrated non-inferiority of the ratio of C-troughs between subcutaneous and IV rituximab with a preset non-inferiority margin of 0.8. The confidence intervals at every cycle, except for the first, were well above that preset non-inferiority levels. So we can achieve non-inferior trough levels of rituximab, which are the key pharmacokinetic parameters, by a switch to subcutaneous formulation. And we saw that across all sizes of patients, even in those patients with a higher body surface area. So the pharmacokinetics were non-inferior. The key thing is in terms of efficacy, and when we looked at the overall response rate and the CR rate between the IV and the subcutaneous arm, these point estimates were near equivalent and absolutely in line with what one would expect. When we looked at the response rates according to body surface area, again, bigger people, a concern that exposure may be less, and therefore a concern that there may be fall off in efficacy in these larger patient populations. And we absolutely saw that the point estimates between the IV and the subcutaneous arms were near equivalent. So across the range of whole body surface areas, the flat dosing has no impact upon clinical efficacy of subcutaneous rituximab. So we also recognise that there was no new safety signal except for perhaps some administration-related adverse events related to the injection. and these were mild and self-limiting and largely a bit of discomfort, a bit of erythema and a bit of swelling. So what we can see is that there's no new safety signal, and the efficacy is maintained in the switch in the formulation from IV to the subcutaneous formulation of rituximab. So this is going to have a clear impact upon patients in terms of the convenience for patients, and I think it's actually going to have a clear impact for the providers, because of course it will release plenty of chair time. And I think going forward, as we see increasing numbers of novel agents and increasing numbers of so-called non-chemotherapy regimens, you can very readily combine a subcutaneous rituximab formulation with perhaps one of the already active agents, and of course that would be incredibly convenient for patients.